welcome back. This is Doc T on SHARC Doc Talk. I'm here with Dr. Deonson, who we all know. Dr. U.
You in the house.
I can't say his last name, so Dr. Nandi.
Sundaram. There we go.
It's not hard.
I'll take it.
Forgot off the top of my head how to pronounce it properly.
That's okay. Nandi's good.
So just to give you guys an update for anybody who might be new or have been seeing this before and you've seen these guys randomly throughout the time, PT, chiro's in the middle. Mm-hmm. So what we're going to do is have a little low back rehab sandwich discussion between two different disciplines. Roughly, how many years you been in practice?
21.
About 8.
3.
21, 42, 50 plus years of experience in here. And so we all realize what little we do know and what we don't know. So it'll be fun. So we're going to jump in with the check-in first. And since we got everybody here, we're going to go full left to right. So Dr. U, what we typically do is we do like a little, 5-minute section of just patients of the week, anything new, funky, weird, something you haven't seen before, something you've seen before, but now it looks different, whatever. And how's your personal life?
On the spot there.
It's a good start. Well, we can do. Let's do this. I'm gonna put it on the spot. Dr. Johnson, why don't you start us off?
Yeah, it's been a fun week. Lots of fun patients.
That was it, huh? All right. I guess I'll go. I'm just kidding. I'm thinking.
Yeah, it's been a fun week. Lots of fun patients where they're doing well, but a couple hiccups in the road, and that's where the kind of the topic kind of came about, where they've been doing good, but then all of a sudden they have a little bit of pain. Trying to figure out why.
A little relapse?
Yeah, a little bit of a relapse, or I like to call them a little speed bump in the road here. So that's been fun to figure out with a few of them, and then started coaching basketball again. Nice. So yelling at little kids is kind of fun.
No, at the high school?
At the high school.
At the high school, nice.
Yep.
So the little kids that are a decade behind you.
Yeah.
Yeah. Okay.
and 4 inches taller.
Yeah, 4 inches tall. More like a foot taller because they're playing basketball at this point. So yeah.
That's crazy.
But yeah, it's been fun.
Nice. That is fun.
Mm-hmm.
Yeah. How do you feel like your coaching chops are?
They're okay. Because I'm like, sometimes you gotta feel like you have to like really dig into the kid because they're just being dumb, and then sometimes they need to be like handheld through some things.
Every kid's different.
Yeah, so I'm trying to figure that out with each of them.
What were you? Were you like, did the coach have to push you, or did the coach have to like coddle you?
No, the coach just had to direct me to where I needed to go because my brain would just be kind of everywhere.
Butterfly, baseball,
I'm like,
butterfly.
I'm athletic,
dog.
but like I don't know what to do here. So
Squirrel.
Yeah, that was my brain. Mm-hmm. So
Nice.
as long as you do this, you're fine. And then
That's good.
Okay,
That's easy. Yeah, be dumb athlete.
Yep. So.
That's the best.
Yeah,
All right.
so that's
Doctor, you want to give it a shot?
Played some golf yesterday.
Oh, yeah.
What'd you shoot?
With Nandi. I don't.
They don't invite us,
I don't
so
keep score.
just that's why we never talk about it.
No, I got invited, but I don't want
Oh,
to.
yeah. I don't get invited.
You're always
We
flying
see the problem.
somewhere.
Never
That's fair.
so-
I was on a plane. That's fair. What you
Yeah.
guys shoot?
I don't keep score. I just try not to lose balls.
I didn't lose any balls,
So
which
but
is
they
good.
keep score of how many balls you lost.
I didn't lose a ball.
Nice.
Good.
No ball lost yesterday, and I had 2 pars.
How do you know?
I keep it on. I started keeping it on my
Oh,
app.
so you keep score.
I do. I like to.
Okay. You just
Mental score.
you just joined the vitamin D.
Yeah.
Nice. There's nothing wrong with that.
Yeah.
Yeah, I like that. It's kind of fun.
Couple bogeys, couple double bogeys. You know, it wasn't
Where'd you guys
bad.
play?
Just Newport Golf
Yeah.
course.
The executive course?
Yes.
Is that what it's called?
Yeah.
Yeah.
Just
So-
the public one. Whatever the public one
Yeah,
is.
down campus in Irvine Drive.
Yeah,
or whatever.
that's a
Yeah.
good one.
Yeah, where Doc T's bench is.
Does he not know the rules?
No.
Is it still there?
Still
So
there, my friend.
Free advertisement.
Free.
They haven't
No,
let-
that was expensive.
And it's still the
It did
same.
nothing, but it's hilarious. It's still there.
I love that it's there.
Yeah.
I love
That's a
that it's
right. I
there.
wish it was more local. What does it say? Is it SHARC or just me?
No,
just
just
you.
you.
me. I don't know.
Yeah. Same
Oh.
number.
That's good. The number is all that matters.
That's all that
It might have
matters.
to be me.
I'll just put my face over it.
And it's no, it's just
You'll get your turn. It's back to him.
But apparently it might not be over there anymore. There's the land. Or Nandi was saying the landowners might change it to like a water park or something, which is
A wave
kind of
pool.
sad.
Oh.
A wave pool.
That side?
in Newport Beach, and so
yeah, stupid.
The oceans, right?
Yeah,
yeah.
exactly.
Go like
so
five
I mean, they got
splits.
a lot of land, so I don't know.
It's a big place, yeah.
So I'm like, the whole thing's gonna be a water park, and they keep half of it a
And they
golf
could
course?
do. I mean, they got the 3 holes that are across the bridge. That could be something.
That's what I'm saying. Yeah.
It's potential, and they're across the street, so they got a boatload of land.
Right.
Yeah.
Wow. Okay. Well,
I don't know. But
how
on
about
that,
patience? Any patience
on
you
that
see?
patient-wise, I had a good conversation about someone regarding more like chronic pain, which is a common thing that we typically see in physical therapy, since it's like a more of a long-term recovery process, and how kind of the mind and body kind of connection makes a pretty big deal about your perception of pain, and just kind of like what are the overall encompassing, I don't know, aspects of what contributes to pain versus just simply trauma to tissue. And that was a really good conversation we had. She mentions a couple of podcasts by her name is Mel Robbins. She's pretty popular personal development person.
Let them
edit that out. You can't talk about the podcast in here. It's not podcast.
Information. Yeah, so stuff like that. So we had a pretty good long text conversation about that, and so.
Well, that's interesting. A text conversation over chronic pain.
Yeah, because
Wow.
versus having it talking on the phone, because sometimes patients will text me about stuff. Say, oh, check this out. What do you think of this? What do you think of that? I'm like, oh, this is something I've dabbled in, researched a little bit too, and I was like, oh, this is what I found. This is some of the interesting things that I've tried to learn on myself. There's books that I've read. One of the good books I've been reading is called. What is it called? Something about not being yourself, like how to not be yourself, basically. And so, something.
How's that possible?
Yeah, so
That seems counterintuitive to everything I've ever been
Right.
told in my entire life.
and so it was just interesting, and so stuff like
That's
that.
good.
So
The titles are always funky.
Yeah.
Yeah, nice.
That was a big thing this week, and so.
Any patients you have with low back issues?
Oh, low back specific.
Low back, hip,
No, mostly just
general vicinity?
front of hip pain, like golfer, older golfer, retired golfer, and retired person playing golf, and so a lot of kind of anterior hip, front of the hip pain, things like
Okay.
that. Mainly with walking up and down hills, especially unstable surfaces, things like that. And so that was a pretty big thing. It doesn't happen with anything else. Driving, that's okay. Sitting down, no problem. But just unstable surfaces or walking on elevated surfaces, things
Got
like
it.
that.
Flat, they're fine. Everything else.
Everything else is fine.
Trout, stairs, whatever.
Yeah, it's a lot of hip flexor weakness, and so we're looking into that.
Nice. Good luck with that.
Thank you.
All right.
Oh, my turn.
Oh, now you're quiet. The guy who doesn't stop talking is now
exactly.
quiet.
Yeah,
Oh, me? Oh, it's my turn to speak? Oh. Well, hold on. There we go.
There we go.
All right.
Thanks. Low back pain, couple patients. Everything kind of trended towards mobility this week for some reason. I do a lot of manual therapy, and a lot of people talk about my manual therapy and say, yeah, all the patients love your manual therapy. And I try to learn about.
Patients love my manual
I
therapy.
know, exactly. Well, David even said if I was Doc T, he would have been crying by then. So, but we dug in his psoas a little bit.
Who, his?
Yeah.
Yeah.
Nice.
Yes, it was.
He
good.
won't let me do it.
He is so tight. Oh my
He's a little
god!
big ball of muscle.
I know.
It's like a scatabo over here.
Well, he did his squats the other day, and I was like, "Are you sure you should be doing that much squats right now?"
Yeah, of course he should. He's young. He'll hurt himself and figure it out later.
Okay.
Like we did.
Yeah.
He'll get there.
Single calf.
Yeah.
And so working kind of because not that I'm not comfortable with mobility, but it's not like my knee-jerk thing to do. And so that's kind of nice to kind of change my brain to look at a patient's mobility, whether it's flexion extension in their low back and what's bothering them most, and kind of gearing it towards that. What was the other thing I was going to say? I don't know. It'll come back to me.
We got time.
Yep. And then I think that was about it. I mean, playing golf with Alvin, my low back was kind of bugging me yesterday, and it hasn't bugged me in a while, but I haven't been doing my bird dog rows, so got to do my bird dog rows.
So that always comes back to the crux of the problem, right?
Yeah.
Sticking to your PT.
Yeah.
PTs don't do PT.
Exactly.
It's like chiropractors throw their back out. You're like,
Yeah.
you're supposed to know how not to do this.
Yeah.
What's the problem?
Yeah.
I still make the joke to my patients to this day. At home at night, I'll sit on the sofa, watch a TV or watch a show or read a book, whatever. I'll stare at the floor and like 3 minutes. Just get down there for 3 minutes.
Yeah.
Do a couple of things, and then you can go back to whatever you're doing.
Yeah.
It's happened like once.
Yeah.
Maybe twice. Maybe twice.
It takes 3
Then I
minutes.
get up and I'm like, oh yeah, I should have done it earlier. Yeah. Anyway, well, let's see. With me, we got. Let's see. We had the low back pain with the one guy. He's actually his quad's coming back. So you guys will catch
that
up
guy?
real quick. Yeah, we have one guy who's L4, L5, like has a disc thing on imaging, but it didn't really match his clinical, right? So I started cruising through and speaking of iliacus and the lateral femoris case nerve,
LFC.
whatever. I'm so old now, I forgot. It's that thing. So we did a little the tendon attachment side of the iliopsoas. We found some stuff in there. And here we are like 5 weeks, and his quad is almost equal. It was 2.5 inches smaller than the other one.
Ooh, wow.
And it was what triggered him was he was having pain, kept running, kept exercising, whatever. I'll just give you guys a nutshell version. Then he has some type of scale that you stand on, and it measures the weight of limbs.
Oh, right. So how you're standing on left versus right?
No, not even that. Just that, but the weight of them. Like
In-body scan?
I don't know what it is, man. You just stand on it and it does this thing.
Oh.
And so he says he's been doing it, and he probably got it more bells and whistles and kind of like something to look at, like people get the Oura ring or Oura ring.
Yeah.
So he shows me from 2 years ago, and he's pretty much within 0.5 pounds, right to left, up and down. Everything's there. Then he said I started noticing it was a pound. A couple weeks went by, it was a pound and a half. A couple weeks went by, it was 2 pounds, and it was up to like 3 pounds. That's plus or minus, I think, half a pound on the reader. And I was like, whoa! When I started measuring, he was 2.5 inches smaller on one side, and that's what triggered him to go start getting work done. So he went to PT, and he went to the chiros, and he got cupping, and he got scraping, he got everything under the sun, but nobody had worked the areas that I worked. So it's like I always say, we're lucky when they have seen other doctors. Like if they went and saw you, then went and saw you, then went and saw you, then saw me. Well, I know it didn't work now.
Right.
So now I can go focus on some other stuff that we haven't tried yet. So I was very fortunate to get it through, and we got the leg coming back. He's the prototypical guy. Can I go run? No. Can I do this? No. What can I do? What I gave you. So I gave him BFR because I tried to explain to him this, and you guys know all this too. Essentially, it's you haven't lifted properly. This leg is deteriorating, small.
Yeah.
So the connective tissue is also weakened. So we have to strengthen that first before you start getting off this running thing. So we got him in BFR to basically say, okay, let's get everything around you. Plus mentally, you get that. You guys done BFR? You guys have done it. Yeah.
Briefly.
Yeah, okay. If you got to do push-ups with BFR on you, it's a nightmare, right? Bicep curls with squatting, lunging,
my
it's all a nightmare, right? So we gave it to him just so mentally he's happy. He's going to go, okay, I'm satisfied with my workout.
Yeah.
And that lasted 2 weeks. And he's still like, can I run? I'm like, no.
I need to run.
You need just, dude, you spent 9 months and thousands of dollars. Now, if he hears this, I'm not making fun of you. I'm just saying thousands of dollars to get better. You're on the right track.
Right.
Just stay there.
Yes.
Now, ironically, just to fill you guys into, this was kind of almost, I felt bad for him on this one. This is a bad day. While this was going on, he got home from vacation. While carrying suitcases up a step, his leg gave out because he doesn't have the quad, among other things, right? Fell on his shoulder. Tore. His little labrum, a little bit of subscap. And I'm like, so he's going to see Dr. Goswami, I think last week. He just got his, I got stimulus on Thursday. I have to reach out to him. But I was like, for the shoulder. So he came to me for the back, and we talked about the shoulder. I worked on his shoulder a few times, but it seemed to make it worse, which in our world means that there's something damaged.
Yeah.
So we work on it, feels better, it gets worse. That means we're taking out the protective mechanisms, they're kicking back on, but now they're really pissed. And so we go back and forth. So he's going there to get that done. Yeah, that's where BFR also came into play. So that was the guy we've been talking about for a while, because that was the case. I'm like, I've seen some atrophy. Obviously, my calf is gone. I've seen that. I get that. This was like the quad was gone. The calf is now going too.
Wow.
And I was like, this is not good.
No.
This is not good. And it's weird because normally that would come with a disc bulging onto a nerve root, hitting the motor side of it all, like mine did, right? It wasn't like that. It was mostly distal from what we found. I can't find the disc causing the problem.
Interesting.
It's the weirdest thing in the world. I'm not saying it's not,
Right.
but it definitely was a secondary finding from what the clinical showed me.
And so you treated the
Basically-
distal portion of his psoas.
I hit the iliacus, and then inside the iliacus, so where they come down,
Yep.
because one's kind of in front, one's in the back, and
Right.
kind of come and meet, right? Right in there, that LFC will come squirting out from the femoral nerve.
Okay.
And that's what I'm thinking he's impinging in there somewhere. And that's what's causing, there's no,
Interesting.
nothing. When I hit the tendon, he jumped off the table, mimicked his symptoms
Yeah.
100% at the attachment site. And he felt better almost instantly.
Yeah.
And I was like, okay. Because he asked, I was like, I have no idea. We'll try. Everybody else has failed, so we'll give it a shot and see what happens. So knock on wood.
Nice. Yep.
Where is it? There it is. Sorry, Jay.
Peripheral neuron. Good time.
Yep.
So it seems like we might have something, but we'll see.
I have a patient very similar who was diagnosed. They did an MRI. He had a car accident, and they did an MRI of his pelvis, and it looks like he has a minor tear of somewhere in his psoas. And so I released his, and he was feeling like some groin pain with some of that radiating kind of almost low back pain, and had some instability in his pelvis. And so looked and treated the side of his psoas on that side, and he was like, wow, that all the tightness and all of that groin pain just totally resolved.
Calmed, yeah.
Yeah.
Now, my theory, I'm not curious what you guys think. Here's how I approach a situation like that, especially. I'm all for releasing muscles. I think, generally speaking, muscles aren't tight, like they're not shrunken up. I just think they're overactive. They're doing too much work.
Okay.
Yeah.
And so we use tight because it's much easier to describe to everybody in the world, and we all kind of get the same language. But in my mind, I'm like, if I release that, what's going to happen when they stand up.
Right, what's holding them together.
So I instantly, and this is from experience, I'm trying to make sure this young man does not go through, where I've released it and they stand up, and collapse.
Yeah.
And I'm like, oh, beep.
Shoot.
I didn't
Darn
say
it.
Just in case, I'm
it.
gonna clean it up.
But I like to go right with that release, right into a bridge or a clam or something, just
Always.
instantaneously to see if we can get him active again. But it's fascinating when you think about, I mean, there has a tear somewhere, which car accident, I can understand that would happen. But man, that sucks.
Yeah, no, he was, but he, and like you said, I'll have them kind of bridge, or I'll have them,
Hip activation stuff.
yeah.
of course
And
so.
he was like really shocked at how, and then have him stretch it at home, but shocked at how much more mobility he felt like
felt
he
better,
had.
yeah.
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 Yeah,
It's
so
amazing
it
to
was
see
nice.
that look on people's faces and they're like, I can move.
Yeah.
So anyway, that was a long check-in. That's my check-in on one patient. I have talked about the sprinter, the teenage sprinter.
Oh, yeah.
I'll be real quick here, just so you guys will fill in. She has, she's 16. She's got legs the size of mine, hamstrings. She has power in her. She cannot turn her hips on. We tried to give her just a supine, squeeze your glutes. Can't do it. Can't even start to. I had her mom feel and check. Nothing. She came in yesterday, I think it was. And she looked at me and she's like, I finally feel them working. When I do these exercises, I can actually feel like my glutes are sore and working. And I'm like, finally, thank God. But she's doing well. We're going to get her back into running this coming week.
Yeah.
And guess which treadmill she's going to start on?
The
curved one?
The curved one. Yeah.
I love the curve. Anyway, I think that's about it as far as low back stuff goes on.
I'd be curious to see her times afterwards too, after she gets back to
She's
training.
dropping half a second at least. She was running, I mean, I think the tops is like high 10s.
Where was
And
she?
she's in like 11s,
Oh, she's right there.
low 11s, mid 11s, somewhere in there. So she's, if you saw her
Low
legs, you're like,
11s,
whoa.
yeah.
For
Was that the patient David was working with the other day?
No.
No. Okay.
That's about it, I think. I got another one from a good friend. She's going to be tricky because there is a disc involvement, but I think it was a disc that caused this, and that inactivity caused this, and that caused that. So I think there's like multiple layers, but that's about it on that one. So she texted me this morning, so we're going to work through that one. So I'm hoping for the best on that. So that's all I got. In silence. Perfect.
Cool.
So when we talk PT and chiropractic, people think that chiropractors are all spinal, PTs are peripheral.
Right.
You don't see a lot of spinal cases in theory, and we don't see a lot of periphery. It's not really true in this office. We
No.
kind of all hodgepodge and dabble around.
Yeah.
And we'll have low back pain patients that I feel like might need to gate this or something that. I'll send them over to you guys. You guys do with this stuff. Because you guys do gate stuff or do things like that well. And you guys might send some to me because you feel like ART, which is the only real difference in our soft tissue technique. You might feel like, you know what, they might be able to find this spot I know is there, I can't find it. And that kind of thing. And that's the beauty of having this multidisciplinary genre, if you will. The fascinating part is when you, like Alvin, for you, for example, I've only been in practice for about 8 years, but you've seen some things. Have you ever had a patient come in and walk you through what they were doing for low back and didn't make you cringe, but you're like, let's try something different?
Yeah, that's a pretty common thing you're going to typically see. It's like you'll usually get like a really blanket exercise regimen for something. Like it's always core stability, it's always core, it's always only glutes. And it's not really addressing like the person's individual deficits, right? If they lack like a hip mobility problem that's causing their back pain, or if it's like a facet problem, like an actual spinal mobility problem, then that's not being addressed. They're just like, just go do some bridges and do some clammies, and hopefully that'll help, right? So like
It does.
but that's not like it's just not
It doesn't fit everybody.
it's not everyone, right?
Yeah.
And so like it's easy to do it, like let's try that. It'll probably help, yes, like for sure. But if you want someone who's had it for a really long time, then we want to try to be as specific as we can to address their particular needs. Like you were saying, like the lateral familial cutaneous nerve, right? Like, I don't know how many bridges is going to help that.
Oh, no, that needs to be treated.
Right. So
Yeah,
like,
there's a tissue treatment process, that is needed sometimes.
right. And so like, so once that's addressed, and like, okay, how do we get specific enough exercises that can help them with their particular needs, and that's pretty important.
Usually, from what I've seen with that, is a lot of times when they come to us, they've actually had a lot of the right answers, but poor execution in terms of like
Also very true.
their exercises. So I had one patient this week where she's always had trouble finding her hips, bunch of low back pain, 2 kids under 2 years, so she's just everywhere right now in terms of pains. So we're just trying to
poor
rebuild
ladies.
her. Yep. But she said, I've been doing bridges, clams, these rotational exercises. I'm like, cool, those are technically right answers. Let me see how you're doing them. Yeah. Did not feel them where she needed to feel them.
Yeah.
So we had to adjust things and made things so much easier for him. So
Yeah.
it's execution, specificity to what they need actually, and that's what I've at least seen in
Right, intention. A lot of it's intention, right? So if
Yeah.
you are doing those exercises, like what's your intention out of that? It's just like to get your hip up. And it's like, okay, like what are we trying to do? If we're trying to get more awareness of the glutes or whatever, awareness of your hamstrings, awareness of your front of your core, things like that, then that's going to be pretty important. It's just like, here, try this and see what happens. And they have no idea what's going on. And so
So I have a question for you guys, because you guys came from kind of more of a high volume area from before as a PT clinic, right? I don't want to just, I'm not talking negative about anybody, but I swear to God, he'll edit out if I do. He always checks me.
I try.
Make sure I'm not,
Unless I'm lazy.
But what do you see different in those settings that you, like, what can't you do there that you can do here? You know what I'm saying? You know what I'm getting at?
I always say
What
like,
limitations are there you don't have anymore?
I always say, like, I never really, not that you're saying that there are bad PTs out there. I'm saying, like, I don't really ever see bad PTs. I see PTs that don't have time. And here we have a lot of time, and we can make as much time as needed if we really needed to. And when you have more time, you have the less of the pressure to be like, I got to figure this out right now. And if you don't.
Yeah, I got 30 minutes, go.
And then, so it's like that makes it a lot harder for everyone. Right. And then you're rushed and they feel you're rushing them and they don't trust you anymore. They don't feel like you're hearing them, things like that. And so simply the advantage of just me and the person are one-on-one. It's no one else. I'm not going to throw you on to someone else either. And so
Like the assistant and go ride the bike for 20 minutes.
Yeah. So,
what?
It's like,
Oh yeah.
Yeah, things like that. And so it's like, we want to try to address the person. We were able to address like a lot of their needs there. And a lot of it's also, you can only do one body part at a time too in other places. Like, okay, they have the prescription for the shoulder. And it's like, well, my back hurts too. Well, it's like, I can't really touch your back because if I document
why is that?
This is an insurance problem.
There you go.
Right. And so,
that's what I wanted to land the plane on. That was the goal. But I wanted you to set it up for me because that is the limitation. That is purely limitation. And not
Very
all
much
insurance companies, but in some of those clinics, the business model is such.
It's the business model, right? I mean, insurance is part of that business model.
Yeah.
And so it can limit what you need. And so I mean, that's probably the biggest challenge for the PT. It's just like, well, we're kind of handcuffed. So how can
100%.
you possibly, really address everything or really treat this person as a whole and assume they're going to get better in a reasonable amount of time?
And what's crazy is I've had these arguments, and I mean arguments, drop down, brawling arguments over the phone with insurance companies because they're people I've talked to are my peers, right? And we'll have these conversations and they'll say things like, well, you worked on their calf for back pain. That has nothing to do with their low back. And I was like, well, it depends on which book you want to read. I can quote you 3.
Right.
And I've actually got rid of their pain because I worked on their calf because that was actually the issue.
Yeah.
And those conversations you have is like, and that's the limitation. So I was always curious. I mean, most of the PTs I've met outside of clinical and just met chatting with, great, the best intentions in the world. And it's never really their fault per se.
Right.
It's kind of funny, like surgeons get blamed for it. It's like the surgery is not the hardest part. It's not easy, don't get me wrong. But it's like when they're done, they close you up.
It's gone.
Now, who do they go to?
Right.
Yeah.
You guys have time, but they don't go to somebody who has time to make sure we're hitting all, like we're seeing everything we need to see. And if we don't see everything we need to see, then we're going to miss something.
Right.
And if we miss something, success rate just plummets. So it's kind of an interesting thing. So I was very curious. What about you?
Same. I go back to actually a conversation that Alvin and I used to have. He would. I had the blessing of him being my student and then working with him, and so
It's the most ironic situation.
It very much
is.
is.
Kind of funny, yeah.
But it was nice because I mean he was an older student like I was, and so he had been through some experience of education and life and stuff. And he would always say, he was like, I'm so conflicted. Like I've got 30 minutes to do this, and I don't know whether to focus on doing soft tissue or exercise, and I want the patient to get what's absolutely necessary, and I don't know how to prioritize that.
Yeah, it's near impossible.
Yeah, totally. Yeah. And that's like one of the great things I see with being here at SHARC is that we do get the time. That was one of the things that I had the ability at where I was working before, and now where I'm working, it's very much that 30-minute time slot. It's very much working with the aides. It's a lot of communication. It's taught me a little bit better communication with my patients in the sense of this is what you're going to get. This is what we're trying to achieve. And if you have any questions, do not hesitate to ask because there's lots of clarifications. And I try to grill that into the aides as well because
That's so hard though.
It's very challenging, but they're really good. I mean, they're good about, okay, I have a question. Great. ask me the question. Yeah. And so, but here it's definitely our ability to have the eye that we need to have, and the time, like Alvin says, the time to be able to spend with the patient, to give them, to explore every possibility, because those possibilities come up in our head in those smaller time slots, but we can't always address them, so they don't get addressed, and then there's something that we kind of miss in a sense.
And it limits your success. I mean, if there's a, and I'm just going to throw out the click terms, if there's a core instability, hip instability, or both, and you have a shoulder surgery patient, you have to address all of them.
Yeah.
Right? They're not separate entities in our bodies, and that it limits that, which means that I always joke with them. I said, well, I can just do this piece, but I'm going to see in 6 months for another thing, or this again.
Mm-hmm.
Like if we truly want to fix it, that takes, and people always, they sometimes don't always understand. If you give me 20 shoulder surgery patients, right, and I do the blueprint on all 20, I might have a 10% success.
Yeah.
I might, because all 20 of them came from 20 different reasons that got them there.
Yeah.
Yeah.
Being trauma, car accidents, slip and falls, wear and tear, older ages, athletes, whatever it is. And so that's where we emphasize, we always push with our clients. We're always trying to say, hey, we do this because we need time. Like you just can't fix, I can treat the pain, and that's cool, but I'm not going to actually fix you.
Yeah.
And I don't want to see you again for this. I really don't. Come in for something else. See you at the store, but I don't want to see you back in this office for this again.
Yeah.
Something else, sure, I get it. But that's interesting. So, Dave, what about you?
In terms of like the length of treatment?
Just
or?
low back pain stuff, but like when you look at them and what they're doing, because we get to watch each other. The funnest thing in here is we've got 5 docs.
Oh, it's fun. Yeah.
Just cruising around this place doing, and everybody's picked up something like, ooh, that looks cool. I want to try that. Ooh, you know what I mean? And sometimes you're like, what the hell is he doing? And then you have to go ask, like, what was that? Because I want to know. And so it's kind of fun. But with you being such a young doc and having these years, I mean, you guys come from a different place. Now you guys are like, your wings are spreading, get to do whatever you want. And you get to see you guys evolve. Plus, then you watch us do our thing. Like, what's it been like for you?
It's been fun. I think the biggest thing that I've learned is like, there's no reason to rush, especially with all the time that we have. That hey, we can spend the hour, and that's actually probably most beneficial, because I know sometimes we'll be starting to work on someone, and if it's like a quote unquote condensed appointment, because they only have 30 minutes of time, we already know what we're working on. They'll be like, oh yeah, I hurt my back. And then all of a sudden, you're treating them, and they're like, oh yeah, and then this hurts, and then that hurts, and then I have to.
You want to see Doc T's face get mad real fast? All right, that's about it. Yeah, also, can you check my shoulder? Tell me at the beginning.
Yeah. So with extended time, it just helps us go through all that too, because it's also a little connected. Whenever we're like giving rehab programs, and all of a sudden your shoulder's feeling better, but also your mid back hurts. Why didn't you let us know earlier?
Yeah.
Just because that is connected.
They're all.
And we have to address that, and that could be where a speed bump kind of came in, and we have to address that in future plans or wherever we're going. So yeah, I still have a bunch of stuff from these guys all the time.
Good,
so.
you should. That's what the fun of it all is.
Oh yeah.
It's interesting because the dynamics of the doctor-patient relationship, and the reason we're talking about this with low back and everything, the good and the bad and everything, is because these gentlemen come from a more speedy, expedited processes. Now they get to do more, which is kind of neat.
Yeah.
But a lot of you out there are going to experience that with either chiropractors, PTs, whatever, where they're a little limited on time, and your back, like the cases I've talked about, you're talking about, these are more complex cases.
Yeah.
This is not as simple, I'm going to hit X, Y, Z, they're going to feel fine, here's the exercises, ABC, go. It's like, it just doesn't work that way. And with these guys, like this guy here, he's on BFR for his shoulder, his back's doing fine. But he came to me for the back. But luckily I took time with him so I could figure these things out with him.
Yeah.
So it's such a paramount process that a lot of people out there, we hesitant because insurance doesn't cover it, or they pay out of pocket. And the reason we say, we understand that piece too, finances are finances, we get that. So those cases, we might do an abbreviated visit. We'll try to give as much info as we can, but there's only so much we can do when we're not watching you.
Yeah.
The way you do things, like where's my quote, the way you do it is more important than that you're doing it.
Yes,
so you might be doing some stuff, cool, but if you're not doing it the right way, then you're probably not going to get everything moving the way it's supposed to. Everything's coordinated pattern. I always say the order operations. A lot of people still remember that.
Order operations, like
mathematics.
Yeah.
Order operations are like, I remember that. I'm like, God, I did not remember that.
Please excuse my dear Aunt Sally.
Excuse me.
I was horrible at those in school.
Foil?
Did you guys have acronyms like that in school to remember things?
Yeah, yeah.
Same thing. I hated those.
Really?
I could never remember that. It was easier to remember what I was trying to remember than it was to remember the acronym.
Oh.
Yeah, I would get stuck like, wait, what did that stand for again?
The acronyms are great. I had one classmate that he would always just put a swear word for every single one of them, but they were like similar swear words. I'm like, dude, you're not going to remember any of this. So he's literally in the test because I can see him. And he's just going for it. And I'm like,
Do you have
dude,
Tourette's?
no, he doesn't. I'm like, dude, you should probably just make a different one.
Yeah, I don't know, expand your horizon a little bit. What was the one for the carpal bones?
There's a couple. So there's one.
There's a nasty one and a clean one.
Yeah.
Okay, two versions. Okay,
Yeah.
that's how.
Yeah.
Yes.
So there's some lovers try positions that they can't handle.
Yep.
That's right.
And then
Oh yeah. Oh yeah.
It's so funny. You're
that's,
going. It's funny when people ask about Cairo school.
Yeah.
Occasionally you're there, and I'm like, all you did was learn how to study really well in one class for the next
Yes.
class,
Yes.
and then you caught up with whatever you missed in the class you just were in next week. It was like this. I don't know. Alvin's probably different, but that's how I was.
Yeah.
So we got really good at that.
so there was
But-
that one. And sorry, Mom, just for that one.
Oh, yeah.
Then
That wasn't that bad.
It wasn't.
No,
yeah,
that's not.
but I know
That's
my
not
mom.
horrible.
It's also so long to pinky. Here comes the thumb. So it goes that way. So you know which one's
That-
I would,
that way.
I would never remember that.
Yeah.
I'd just rather remember. Anyway, so back to the back. Anyway, so post surgery, guys. Anybody here, all of you guys included, done a post surgical?
Yes.
Yeah.
What's the most common one you guys have seen?
Disectomy
Yeah.
or fusion.
Yeah, it's like me.
Fusion is common.
Probably once or twice a year. Yeah.
Okay.
Yeah,
More
mastectomy.
disectomies.
I've had like 3 this year.
Okay.
Disectomies.
Yeah, I was like, oh, it's the most I've seen in a long time.
What's
Mine's
the
like two.
two? Say it.
I've had like two.
Two.
No.
What's the success you've had with them?
They've all been pretty good, actually. Right after surgery is like completely pain resolution. The problem is the nerve problem. They still have a significant numbness for probably over a year post-op. And
Yeah.
whether or not that's going to come back is kind of like a crapshoot.
It's horrible. Yeah.
From what I understand and from what the physician kind of talks about, it's just kind of like,
He has
it is
no
what
idea.
it is, right?
Yeah, because you can't really test the severity of damage to the nerve, and it's a time thing too. How long it's been going on. But how about you?
I would say, well, the one case that we're talking about with the numbness in the leg, that's to me probably the first time I've seen that in a long time. But for the most part, it's pretty immediate. The pain.
Pain for sure.
Pain
that
for
was
sure.
the pain generator. Yeah, no doubt.
Yeah,
there.
and then it's a matter of, okay, are you going to buy into everything that we ask you to do? And
Interesting. So that's the hardest part too, right? Because you know in your minds as doctors, right? You know this. Whatever got them there hasn't changed.
Yeah.
Because of surgery. Surgery didn't fix that.
No.
It just took the pain generating tissue, which is very specific
Yeah.
in those severe cases, right?
Yeah.
And those are very rare. Like they seem like you've had a lot, but truly of the surgeries that go on year to year, that's way down the line these days.
and then you get the question of, so how long am I have to do this for?
I was going to go right there next. Like how long your guy did successful? Like what's the timeline usually
What's kind of
for treatment? Not so much the numbness and that.
I mean,
unknown.
I'm kind of scooting away from your that direct question, but it's like we're kind of fortunate. The people that we've seen here from this, like they've all kind of had this realization that they have to have this like long-term fitness plan for the rest of either the rest of their life or for at least for the next year.
Yeah.
Because the injury in itself and the surgery itself kind of like, was a kind of shot in the butt. It was like, holy crap, like was really debilitating and I can't do what I was able to do before, which is a lot of like running or higher level activities. And now that I can't do it and they were unable for 5-6 months, right? And so they're like, man, I really want to not do that ever again. And so I'm all bought in now. I need to do as much as they're like, however long, then I'll do it. And I was like, okay. And so that was kind of a shock to me because in the past it's usually like you said, like how long do I need to be here? Because I feel great. And it's like, but do I need PT for another 3 months? Like I already feel fine and the pain is gone.
Yeah.
Right. So a lot of it is goal dependent. But I mean, ideally, if they can stick around for at least like a couple months, to allow 6 to 8 weeks of like simply tissue healing to happen, that'd be great. And then give them some education about how to programming them some sort of a higher level exercise versus stuff on the ground or on their back, and to start doing things in standing and loading of tissue, which what your bones really need. And so eventually hopefully getting them to that as soon as possible before they leave.
That's the biggest crux. I think our biggest challenge, and Dave's seen it over the years too, I know you guys have experienced it, but is that piece. You're like, it's 6 to 8 weeks, but you're not going to be here 3 days a week for that.
Yeah.
Like we're going to, slowly build you out, maybe once a week, then once every couple weeks, and just kind of more manage you and make sure we're on the right track. Right. But that necessity, because otherwise that's a joke I make. You can be out of pain, we can give you these things, and you feel like you're happy, like I say, bridges, clams, hand taps, basic core work. That's like learning to crawl.
Yeah.
Right.
That has nothing to do with gravity, sports, existing in this world, right?
Yeah.
Nothing to do at all. The getting you there to there is pointing to point B, not hard. A few weeks, not hard, no big deal. Done. People assume then we're done.
Yeah.
It's like, well, no, we haven't worn to walk.
Yeah.
You know what I mean? And they make the joke, but it's real. Like you
No.
can't, your body, especially when you have that back that developed over months to years, unless it was a trauma, of course, that movement pattern system, all of that is still there.
Right.
You get off the table, you got a pain, you're still moving like not well.
Yeah, we always like to say like, oh, we want to try to get you back to better than normal because normal got you here.
Yeah.
Right. And so you want to be better than normal.
Yeah.
And that's the thing that I have to remind myself about is that, you can be great on the table and do all these exercises where you're at home and doing all this good stuff. And then you finish the exercises and you get up and you walk away.
Yeah.
Well, what are we going to do now when you walk away?
It's funny, I always ask the interns, he knows too, but I'll explain to him that concept. I said, what do we do by putting them on the table? What do we take away? Gravity.
Yeah.
Now, if they don't have gravity in their system anymore, their posturing muscles don't have to work.
Yeah.
So they're going to be relaxed, if you will. And you give them exercises, so you're teaching movement patterns, which is great.
Yeah.
However, when they get back up into gravity again and it hits the system,
Yep.
the body wants to divert back to the path of least resistance.
Right.
Every time.
Yeah.
So you have to learn to get from point A to point B with that, because that gravity is no joke.
Yeah.
And when you get into it and you start walking, think about your guys' lives. You're managing your house and stuff, kids and stuff. Like, you're still single, lifting a lot of weights. Oh, you're not single. I'm sorry.
Girlfriend.
He has a girlfriend. My apologies. They're official. It's official.
Yeah.
We can announce it on this podcast. But it's like you have these day-to-day routines. Not to mention our jobs are physical. So we have to look at them. Like we have a fire crew or first responders. Like you've got to carry a 250-pound man out of the building.
Oh, yeah.
Bridges and clams aren't the end point.
No.
This is just entry level.
So that way you can walk into the office without being bent over?
Yeah.
Maybe we do that.
So that's a good point, Alvin. It's the one thing that we try to convey. And it's really hard, even with having interns or assistants, we have interns here all the time, to get them to be where your brain is. So if you give them something, like go do X, Y, Z with this patient.
Yeah.
And then you're in your office treating somebody else and you kind of peek out the window and you're like, oh, that's not good. Right? Because they don't know what to look for.
Yeah.
They don't know. I mean, I can teach and teach and teach, but there's still, everybody has so many nuances. You can't always teach everything.
Yeah.
Right? Like the biggest one I think I teach you guys is looking for their compensations while they're doing this. And they go, what do you mean? They're doing bridges and they're holding their breath. If they're holding their breath doing bridges, that's a problem.
Yep.
Big problem, right?
Totally.
And I go, doing clams, I had one girl got a calf cramp. I go, why? And they go, I don't know. Think about it. They're using your toe. Yes. Now I think they're walking. Yes. So you got to relax that, right? Yep. So it's these little nuances over 20 plus years that you guys have, it doesn't matter. You've seen these and you smile because you're like, oh boy, how do I teach you all of these? I had one person that made fists every rep of a clam. And I'm like, my God, it's not that hard. It's not like, it was too funny. But those are the things you're looking for. And then conveying that to the patient that, hey, these are the things you have to go through.
Yeah.
Go through a little checklist, A, B, C, D, whatever. Relax, breathe. I mean, you see somebody try to do just a little brace and their neck comes off the table. And you're like, oh, geez.
Yeah.
That's not good, right? So those nuances. So that's what makes it kind of tricky too. So you get a new patient coming in from a referral from a friend after back surgery or a doctor, and you're going, I've got to learn this person's 40 plus year history in 25 minutes.
Yeah.
Game plan it and get to work and impress them enough they know that I'm competent.
Yeah.
Yeah, I think another point with that too is like, when do you load more, right? Especially coming after a back surgery, which is pretty significant. It's scary, right? Like I don't want to make it worse. I don't want to put
especially
a back squat.
Especially if it's a bad one.
Yeah. So like, how do you know? I mean, you guys can answer. Like, how do you know when they're ready, right? So let's say 6 weeks later and they feel pretty good, pain's gone. It's like, okay, when do we start deadlifting? When do we start, holding a kettlebell?
This is literally the
next
biggest
day,
debate.
right?
If you want to talk about a debate in the low back arena, because you got all these people out there with all these theories, but it's always the greatest question, and that's where the clinical part comes in. Right. You have no idea. Yeah. I can't tell you how many people you've seen. I keep looking at Dave. He's been here like 3 years, so he's watched me for 3 years. So he's seen me go through all kinds of sporadic stuff. Yep. And hey, Alvin, I know you got to cut out. If you want to get out of here, you can.
Fine. Yeah.
Okay. But there is that big debate on this, and it's seeing the client, because not everybody adheres to those plans. Right. So we have to figure that out. And I've had people where I've taken, what did I do? We went from a clam, I think we got him up to, it was like a marching bridge or something, some alternative, trying to just destabilize them a little bit. And their back spazzed up on them. And I was like, okay, so that was the wrong route.
Right.
Let's back you down again and let's try a different route, because something's not firing in there.
Yeah.
And that's the part that we can't see inside of you. An MRI won't show you what is or is not firing properly, how it's firing, the order of operations of firing. We have to see that through watching you move.
Right. And totally. And like I think also with the patient's point of view, it's like they're waiting for like that permission too. Like they're waiting for the transition from can I go from lying on my back to running, right? You're that, right? And we've
Yes,
talked about because
exactly.
they want to run,
Yeah.
and so we're here to fill that gap. And I feel like as a provider, and for me personally, that's the hardest part. Is like how do you fill that gaps where you're not getting step backs is part of healing, right? But these step backs are not so big, or these dips are not
Small.
so big, right?
Yeah.
As
Yeah.
minimal as possible.
Yep.
And that's the one I always try to like, okay, let's make sure, because I've had them before. It was like you said, like just flared up super fast. Like whoa, like where did that come from?
Yeah.
And so you have to kind of regress a little bit into that and build them back up. And
Yep.
so you don't want to frustrate the person. You don't feel like they're getting worse or anything like that. But at the same time, they need this eventual progression, this loading of tissue.
Yeah, and it's funny because we have one guy. He's here. He's not have a last name, but he's coming in. He's all in, doing everything he can to get his body like where it wants to be, and he's progressing in a way I can see, where he's not shaking and vibrating, more reps, more weight. He's doing better, but he still has this tendency to want to hold his breath.
Yeah.
And that's I don't know what he's now, but 35, 36-year-old habit.
Yeah.
That's really hard to break.
It is.
And so
Very
our
much so.
challenge is like, well, I know what you're doing in front of me. We're giving you exercises. We videotape and take pictures, send them out. They come back, then we have them illustrate the exercise on the table again. And 99% of the time, it's not even close to what we did, which means they've been doing that the last 4 days.
Right,
And you're like,
exactly.
oh boy, okay. So you try to walk them through again. And those are the frustrations, right? And it's
Yeah.
not frustrated with the client. That's not their fault.
Right.
That's us. Either we didn't teach it or cue it properly or well, or we did not convey the importance of something was miscommunicated,
Right.
which is fine.
Right.
We're going to correct it now. But those are the nuances. So when people ask, that's a great answer you had. How long is it going to take? It's like,
Yeah.
well, it kind of varies.
Yeah.
Depends
You
on
know?
the person.
The other thing I hear too is plateau. People get kind
Oh, plateaus.
They
That's
get
just
stuck on the
readjustment.
word- yeah,
Plateaus are weakness leaving the body.
of yeah. Okay.
It just takes a minute to leave the body.
Yeah.
That's all it is.
And I always say, plateaus are normal.
Yeah.
We almost want plateaus because then it gives us an idea of, okay, where are we now?
Yeah.
And where were we?
A new homeostasis, really.
Yeah, and then where are we going to go? The biggest example I always give, because this was the biggest one that in my probably the first year I was working, I had a patient who was a recreational tennis player and had shoulder pain for probably 10 years. Oof. And they finally did shoulder surgery. He had a Bankart repair. He had a labral tear and a capsular repair, and surprisingly enough, didn't have any rotator cuff involvement, which was, I think, the thing.
Oh, the muscles, you mean?
Yeah,
The vertigo cuff,
I
yeah.
think that was the thing that saved him.
Yeah,
And-
100%.
And it
Yeah,
took
100%.
him probably a good 6 months to just kind of get to the point where he felt comfortable kind of reaching overhead for like a serving motion. But
I
Connective
hate
tissue
to
is
cut you off
heal.
real quick, but just to explain, it's actually all the hardware in the actual shoulder for everyone.
Oh, yeah,
out there.
yeah.
The
They don't know
labral
what
tear,
a
Bankart lesions, like those. That's the actual hardware. The bones, the labrum.
It's the connective tissue and things of that nature,
That was
not
damaged.
muscles.
Yeah. So the rotator cuff will generally involve a muscle repair, a tendon repair to the bone,
Some fraying or
but everything
something,
else
yeah.
is just all the connective tissue around the shoulder joint.
Yeah.
And he would come in and he's like, "Oh yeah, I feel like I haven't done anything. I've been doing all my exercises every day, and I feel like I'm stuck." And then he'd come in like a week later and be like, "Oh yeah, now it feels better. I can reach way up here." And we sit, and I was like, "Yeah, okay, yeah, no, he's just plateauing and going up and up and up and up and up."
Yeah.
And
Gotta
so
adjust.
I feel like that's like a really good example for certain, especially patients with low back pain or low back injuries, where they are going to go through, like we talked about, on the table. Okay, you're going to be on the table and you're going to do all these exercises, and then we got to think about getting you on your feet and doing things a little bit more functional so that you can actually walk around without pain and walk around with stability and walk around.
And not the fear of hurting yourself
Yeah,
again. Yeah. So low backs have always been a wild, crazy ride. I think I tell people a lot of times, and they ask, like, how does this happen? I said, well, it's hard because I haven't followed you around for your whole life. So who knows? No traumas, whatever. But honestly, to me, sitting, not for postural reasons, but because you got the whole backside of you stretched out. It's like as elongated as it can get. And it's not going to contract unless you're taking your feet and pushing into the ground, right? Which nobody's doing in a chair. So to me, that's kind of been where we see this.
Yeah.
I joke with people, like, we move wonderfully until we get to school.
Yeah.
then it just goes downhill.
Yeah,
Because
totally.
we spend, days on end, and we're like, unless they're in sports or doing something active, but it's hard to offset those hours. But I said those are the things, and a lot of things are built in from years and decades prior, so we're trying to get through it. So the plateaus, you're right, especially in low backs, because most people here are going to sit 3 hours a day to some degree,
Yeah.
whether it be breakfast, lunch, dinner, driving, carpool, whatever.
Mm-hmm.
And so that kind of offsets things, So there's always these little things you have to kind of work around, or you have the ones that like, I'm just not going to stop doing this. Okay, this might take a minute, just so you're aware. So yeah, so it's a very fun, funky thing, but I really wanted to have you guys on here, so I'm glad David got you on here, because I really wanted to have this different perspective from people who came from doctors that came from one style of treatment or business model, if you will, and came into another one. And then, because when we spoke earlier, we were talking about some of the bad examples of PT, chiros, things like that have walked in, and we're like I had somebody had severe low back pain, they had him doing goblet squats, which is a great exercise, but not right off the bat. Right, they're already having compression issues. They're just going to have even worse compression issues now, right? My favorites were always PT, the jokes. I had one years ago. A rower came to me. Her back started hurting her after 30 minutes-ish of rowing, and so she went to the rower PT. And I said, why are they the rower PT? Because they have a rowing erg in their PT thing. I was like,
That's it.
okay.
I guess
Let's go to the next question. What did you do there? Well, I got on the rower for half an hour, and then they did soft tissue, and then I did a couple exercises. And I said, wait a second, but doesn't your back hurt after like 15 minutes of rowing? Yeah. Okay. I was like, I don't want us disparaging it. I don't know what they saw or what they thunk. No problem. We're going to go a different route, though. Yeah, we're going to go a little different route. I still see that patient to this day, too. We kind of laugh about that back in the day. But those are the things, is like their situation might have been, like you guys where you came from, where that's kind of what they had to do.
Yeah.
And in their minds, like, well, let's try to do this and see if we can get her better and treat her and fix her and whatever. It's just how it is.
Yeah.
And the low back is a tricky thing. So for you guys coming in, it's nice because I like to hear a different perspective on things.
Yeah.
We talk about plateauing low backs. Yes, happens all the time. It is one of those things, especially when you get gravity back installed, you got to fix that piece. So people out there, we tell them, just to kind of fill you guys in on if you guys, do you guys even watch the podcast? I'm putting you right in the spot.
You can say no.
You can say no.
Sometimes.
Sometimes.
I see the Instagram feeds.
Do you just go to the clips, the good stuff?
Yeah.
Yeah, the meat?
Yeah.
No potatoes.
I already heard it. I'm hearing it now.
I kind of live it, so
I have to edit
I don't
these.
want
So
to
I
hear
listen to this 4 times in a row.
Dave's got it memorized and come with his own acronym for them all. But it is kind of a cool thing because you can see that when you're in a place and you're not getting better the way you think you should,
Yeah.
even if you're with the best therapist in the world, you have to be realistic about what it is. Are they limited? Are you limited? Like, are the limitations surrounding this whole process? And then if it's not working with the person, there's nothing wrong with finding somebody else. Like all 4 of us are going to take a low back pain patient and probably attack it from a little bit different directions.
I just said this to another person earlier this week too, because someone
You quoted me?
no said
He quoted the podcast. This is what he did.
Oh, I love it.
I was like, if I can't fix you, you're probably gonna have to go see Dr. Travis, like, because it was very specific, sciatic nerve positive, straight leg raise type of thing,
Right.
and I was like, okay, I'm gonna do some things on you. It doesn't help in a couple of days. You're gonna go see him. Like that's just it. Because like I think pre-planning and framing people on day one is really important.
I agree.
That way they know like what's happening. I think Dr. Travis does really good about that in the beginning. It's like, this is what's going to happen. These are what we expect, right? And if this doesn't happen, like this is how we're going to pivot, right?
Yeah.
And so I think that's really important. And so that way in 2-3 visits, if we're not getting better, if it's like a slow progression, it's not so kind of scary for both people. It's like, oh, okay, he already told me like it may not happen. Things may not change too quickly. And so
Yeah, that's the big, we talked about this, I think David and I in the first set of this grouping here, this pieces. What do you call it? Part 1, 2, 3, whatever. But we talked about that where your therapist really should be, I hate saying therapist, your doctor really should be setting you up to succeed. And if you guys don't within a very limited amount of time, based on the severity, of course, then there should be a pivot point. And if you're not seeing a pivot, then you're definitely not in the right spot.
Okay.
And then you have somebody, doctor, I don't care who they are, that's following a script regardless of the new input.
Yep.
Right. And that script is not, I've yet to see a script. I mean, maybe 1 out of 100, it's just perfect.
Yeah.
This script was written for you. Right. Not the rest of you, just that one. So that's kind of the advice we give when we talk about these podcasts, is because people who listen to these we're trying to fill in that void, that blank for them. Like, what do I do? Where do I go see? Who am I seeing? I'm seeing somebody that's not working. What? And so we want to answer that question of just make sure if you're not pivoting and changing course, like that rower, for example, she was going to that place for 3 months.
No change.
Twice a week.
it's a long time.
And I was like, you should have been gone like the first week.
Oh yeah.
You know what I mean? So, and it's always hard. She was young, 15. So
Yeah, that's tough. 'Cause you don't
15-year-olds
know.
aren't
They don't know.
in total tune with their bodies.
Yep.
Most, right? So I give a quarter to that part of it all, but it's like there should be a pivot point there for sure. If you're doing something, and we do it all the time.
Yeah.
There's been how many times have you guys in your career? It's a great question. On the third visit, you're like, we should have pivoted on the second.
Yeah.
Like I saw something, I see it again. We got to pivot now. This is bad. We're going the other direction.
Yeah.
You know what I mean? It's like you got to adjust to that and challenge yourself and not think that you know it all and my way is the best way. Trust me, my thumbs aren't the answer to everything.
Yeah.
So I go agree.
Well, yeah.
Anybody else?
No, yeah, I've done that a couple times. I might have to do that with one patient right now. It's like we're plateauing, but not in a good way,
Yeah,
like that way.
right.
It's like you're feeling good for like a day, and then everything kind of comes back. So let's figure some stuff out
Yeah,
together.
something's missed.
Something's off.
there. Yeah.
Yeah.
Those are the worst.
Yep.
Yeah.
But yeah, that's
Alvin?
basically that.
No, same. I mean, sometimes on the first day, I'm just like, oof, this person we may need to pivot this, punt this, like, to someone
yes.
that can help this, like, because I know where my limitations are.
For sure.
And so it's like, okay, like I can try to figure this out, but like I don't want to waste this person's time too. And so, what's it called? Because they're paying a lot of money for this, right? It's not cheap. And so, I mean, we provide a lot of value, but at the same time, it's like, okay, like let's make sure they get better. It's just better for everyone. And so,
I think our value is also in that we will punt them.
right.
Yeah.
We'll take them and say, you know what? I see what's going on, but I want different eyes on this. And that, I mean, a Dr. Goswami, who we go to,
Yeah.
we love, does ultrasound for the but does some imaging. Just get some other eyes. Just make
Eyes,
sure
yeah.
there's nothing, because it's not all lining up the way, I hate to say the way it should be, but when you're in clinical, there's a lot of things that it should, these things should line up. And if there's something that's deviating, then we have to figure what that is.
Right.
And I don't necessarily want to see you again until we know what that is.
Right.
Doesn't happen often, but when it does, it's a good pivot point.
Yeah, I've seen someone with like severe back pain, and unfortunately, it was with a friend of mine, a family person, and I was like, whoa! It was nothing was kind of changing. It was a lot of pretty significant pain, and then she came back to me, and she was like, dude, he's got significant bone cancer. So it's like crazy stuff.
Yeah.
And so it's not.
Those are the wildest ones.
Yeah.
I've only seen a couple of those in my career, but they're just like, what? This is not
I've
making
had
sense.
one.
And they go and you get the news and you're like,
Yeah.
I haven't had that yet, but no, it's gonna happen.
if you're lucky enough to never see it, that's amazing.
Yeah.
Yeah. Because that's heartbreaking.
it's more bound to happen than it
yeah.
is. Yeah.
All right, guys, we're going to wrap this up. Not because Alvin has to leave it all. We just rambled on for about a good almost an hour. That's,
Right.
that's
Oh,
good.
52
Yeah,
minutes.
it goes by
Pretty good.
That
fast.
was pretty good.
So as usual, any questions out there, shoot us a message or DM, I guess you call it.
Both are technically.
Yes,
Yeah,
yeah.
what do you call it, David?
I say DM.
The DMs, okay.
But I know
DMs.
it's switching. I know some kids are saying PMs now.
PM?
PMs.
Private messages?
Private message.
Private message. Okay. Well,
Direct message.
Just get to us at some
just send
point.
us a message. Yeah, give us a call, shoot us a text, whatever.
You could send us mail. Well,
We get a letter in the mail.
I would
That'd be
laugh if we
fantastic.
did. Like,
That'd
hey,
be dope.
That would be rad.
I would frame it.
I'd fight over being the one who gets to read it and respond. Yeah, that'd be awesome. Anyway,
like
we're going to wrap this up. Catch us next time. We'll probably expound on this a little bit and then move into another topic to cover. We'll try to have the PTs on here again because it's nice to have you guys on.
Yeah.
I always love the mindsets, the points of view, the experiences. It's a good culmination to have, and we do a pretty good job. I still talk
Relatively
too much,
decent.
but I'm working on it.
Yeah, but you're
I'm
a good
aware.
MC, and I like the way you lead our brain with your brain, because your brain is super active.
It's very active.
And-
It's slightly caffeinated today. Slightly.
As it should be.
Yeah,
It wasn't
right.
our normal coffee.
No, that one I can't wait.
That one will be fun.
Yes. So
coming.
all right.
You guys saw it on that one where I was all over the place.
Oh my yes. Like, wow.
But I appreciate the direction that we go and the thought process, because it we do a lot of the same things every day.
Yeah.
And not that our patients aren't the same people, but we're seeing a lot of the same people every day, and it's nice to have the change and the expansion of our thoughts and talk about
100%.
stuff.
And I
Yeah,
love,
it's
I
good.
mean, somebody gets to watch this and catch his tail end. They got 4 different doctors with 4 different years of experience kind of talking through what we go through, and one of us is going to say something that'll resonate
Yeah.
with people out there that they haven't heard before.
Yeah.
And I go, oh, that makes sense.
Yeah.
So, all right. Well, I'm Doc T.
I'm Nandi.
Dr. David, no, your hand was that way.
Dr. U.
Yeah.
We'll catch you guys next time.
That was like quite